Good morning, everyone. Welcome to Pediatric Grand Rounds. Thank you for joining us today. Our speaker is our very own Dr. Alison Estep, one of our soon-to-be graduating third-year residents. She will graduate in a few months, but she will be staying here through September due to taking time off to have her second beautiful child. After that, she will be practicing general outpatient pediatrics in Marietta, Ohio, with Akron Children's. Please join me in welcoming Dr. Estep.
All right, well, good morning. So my grand rounds is titled Pediatric Dermatology through the ages, so we're just going to do a little rapid fire review of some common pediatric skin conditions. So objectives are just to review some of these skin conditions, develop some differentials for case presentations, and then identify which of these require further intervention or treatment. Starting off with the newborn period, these are some things over here on the right that we'll cover. We'll start off with a case. So you're seeing a 3-day-old for a newborn checkup. The mom is concerned about this rash that broke out the day before. Pregnancy and delivery were uncomplicated. You're seeing this infant and they're very well appearing, alert, and appear hydrated. The rash is described as yellow papules and pustules that are surrounded by a large erythematous ring, and it's mainly on the trunk with some on the face. And that is what the rash will look like. So we will come back to this. First thing is milia, which are white papules caused by retention of keratin and sebaceous material, usually on the nose, cheeks, or chin. It is present at birth and it'll resolve within the first few months of life. And in this picture you can see the little scattered, if you can see my mouse, little scattered white dots. And then this is not to be confused with sebaceous hyperplasia, which are small white to yellow smooth papules, and these are more related to maternal hormones, particularly the androgens. No treatments required, and they will resolve within a few weeks to months after the maternal hormones leave the body. Then miliaria rubra, or a heat rash. It's more erythematous and papular. It's caused by obstruction of sweat ducts. It's worse in hot and humid environments, hence the heat rash. It is transient and self-limited, and you can kind of see in this picture, it tends to be more severe and concentrate along the folds or areas where are going to be the warmest. And once you kind of take the layers of clothes off these babies, the rash usually improves. Then we have transient neonatal pustular melanosis, which are vesiculopustules that rupture easily and leave a round kind of scale or hyperpigmented macule. It can be diffuse. If you stain these lesions, they will show neutrophils, and it is a benign and self-limiting condition. So on this picture, you can see like around the scrotum and on the thighs are the more vesicular pustular lesions, and then more up on the trunk are where the hyperpigmented macules are. And then, kind of not to be confused with, and you want to make sure you distinguish from HSV, I think we all get a little bit nervous just whenever we see vesicles because of this particular diagnosis. These are grouped or single vesicles on an erythematous base. They can develop into pustules, crusts, or erosions. They are located both on the skin and the mucous membranes. They usually pop up around 1 to 4 weeks of age, and these babies can present kind of ill-appearing with some vague conditions to respiratory distress, poor feeding, lethargy, hepatomegaly, or seizures. If and when you do lab workup on them, you will see a coagulopathy, transaminitis, and then in the CSF will show pleocytosis. These are treated with IV acyclovir, and we do get very worried about it because the mortality rate has been very high. So with the emergence of the treatment, and like we widely use IVA cyclovir to treat this, the 1-year mortality rate for CNS infection is 4%, and then 25 to 30% for disseminated disease. Prior to the use of acyclovir regularly for these concerns, the mortality rate was around 80%. And then also, if just a side note, if you're treating babies in the nursery and you see a baby who was exposed to maternal HSV and they're well appearing, and mom has a known history of HSV, at 24 hours of life, you want to obtain some surface cultures and check the blood for HSV. Similarly, if the same baby, asymptomatic, well appearing, but did have a positive exposure to active lesions, but for this mom, the lesions are new, she doesn't have a prior history, you want to do the full septic workup at 24 hours of life, not just the blood and surface cultures. You want to wait till 24 hours because if you do it immediately after birth, it can have false positives just from maternal colonization that way. Then neonatal cephalic pustulosis or neonatal acne, as the name suggests, these are pustules. They occur around 3 weeks of life. They do resolve spontaneously. Some of them can be fungal associated, which you can try an antifungal preparation or even a mild steroid if it's really severe or distressing. Then sucking blisters, these are single non-inflammatory vesicles or bulla, more commonly on the dorsal aspects of usually the hands, fingers or wrists. Anytime we see a vesicle, we should kind of have an infectious differential in our head. But these babies are going to be otherwise well appearing. The lesion will rapidly dissolve and then, or resolve, and then a lot of times you'll see the baby go and suck at the area of where the lesion is, so that can also be like your confirmatory diagnosis. Oral inclusion cysts, so different terminology for where they're located. So I believe it's pronounced bone nodules are on the alveolar ridge, as you see in this picture. And then they're termed Epstein pearls if they're located kind of back on the palate. They are small keratin-filled cysts. It is very similar to milia, just in the oral cavity, and then they resolve spontaneously within a few months. Sometimes parents will bring these babies in and say, oh, look, my newborn has some teeth, and it's actually these Epstein pearls or nodules. And congenital dermal melanocytosis, which I think we are all very familiar with. It's a blue-gray pigmented lesion. It's due to delayed disappearance of dermal melanocytes. The prevalence varies with ethnicity, so it's more common in Asians and the least common in Caucasians. It is benign and it fades within the first to second years of life. Usually it can persist though into adulthood, and you want to be sure that you're documenting these in your well child checks, because if something were to happen, there were questions, they do resemble bruises, so if you have been documenting persistently that these are there, it's more likely that it's just this lesion rather than a bruise that will resolve. Then cafe au lait macules. These are flat brown macules or patches that are present at birth. They are benign but can be associated with different syndromes. So the first one that we think of is NF1. With NF1, you'll have 6 or more of these, and the borders of them will be smooth. So I believe it's, if you think about the saying, it's coast of California for this one. And then McCune-Albright syndrome, you'll have the cafe au lait macules, but they'll have a very jagged border. So these ones are the smooth border, but the McCune-Albright will have a jagged border. And the saying with that one is they're termed coast of Maine. That's more jagged. McCune-Albright's also going to be associated with some other findings such as bony dysplasia, metabolic dysfunction, or disorders of sexual development. And subcutaneous fat necrosis. These are indurated, well-circumscribed, nodular erythematous plaques. It's thought to be related to perinatal stress, so sometimes the asphyxia or hypothermia. Sometimes they can be associated with hypercalcemia, which we should keep in mind because we want to follow that very closely. If so, they will resolve within several weeks. And then going on to some vascular birthmarks. Most commonly, we see this nevus simplex, sometimes the anemicus. They're benign and usually insignificant and will fade with time. The simplex is the red, more red appearing ones, usually on the nape of the neck or in the middle of the forehead. So also termed like stork bite or angel's kiss. Then the anemicus one, like the name suggests, is more white appearing. You want to be sure to distinguish these from hemangiomas and port wine stains because those require some further treatment or management. And then looking at the hemangiomas, so you can have various presentation of these, but the ones that are more commonly think of are the bright red raised papules. They can be kind of nodular or plaque-like, as you see in this kind of top, I guess, right picture. The top left picture is one of the early hemangiomas. They will appear more vascular in appearance and then progressively develop over the first few days of their life. The one below that in the bottom is a deep hemangioma, and these are usually skin colored with, you can kind of see the bluish hue underneath of it. It almost resembles a bruise. The management of these depends on the location and severity. So if they're uncomplicated, just routine monitoring is sufficient. Sometimes you can use a topical beta blocker, but noting that you do have to treat for about 6 to 12 months if you're going to treat them. Then more complicated ones are treated with oral propranolol, again, for around 6 to 12 months. So some reasons that you should consult dermatology are if they're high risk or you're considering to start a medication. And if you're wanting to consult derm, the sooner the better, so they like by around a month of age. The high risk areas are in trauma-prone areas. If you had one in like the diaper area, if one of the lesions began to ulcerate, if you have any hemangiomas on the lips, nose, or ears, if they're larger, so greater than 5 centimeters, or they have a more diffusely nodular or pebbly surface on top of them. So in this bottom right picture, you can see that this one is on the lip, so strike 1, and then also it's starting to ulcerate, so strike 2. So this one would need more urgent workup or management, I guess. And then port wine stain. This is a congenital low-flow vascular malformation of capillaries and postcapillary venules. It is blanchable, usually bright pink to red. They're flat, painless, and although they may look like they would be warm to touch, they're the same temperature as the surrounding skin. They're usually unilateral or segmental, that spares the midline. These don't regress like the hemangiomas would, but rather grow and become darker and thicker. They can be associated with glaucoma or some tissue or bony overgrowths, and associated with several syndromes, most notably the Sturge-Weber syndrome. And so with Sturge-Weber, kind of like in the picture, will most commonly be in the V1 or V2 distribution on their face. Management for these in newborns with ones on the face, you want to refer them to ophthalmology. And then, of course, if they have any signs of neurological symptoms, especially seizures, you want to send them to neurology. Otherwise, it's just watching and waiting. Sometimes the treatment is purely cosmetic, and if so, they usually use a laser therapy to help bring the color of it down. And cutis marmorata is symmetric mottling. It's caused by a vascular response to cold, so that you have dilation of these capillaries. They do resolve with warming, and you want to distinguish it from CMTC, which does not resolve with warming. So the CMTC that we were talking about is rare, but it's more darker purple or blue marbled appearance, again caused by the dilated blood vessels. Some areas on this can have an ulceration or even an underlying skin defect, such as aplasia cutis or complete absence of the skin in that area. Some other findings that you may see with this are kind of muscle wasting of one of the limb, smaller limbs, or glaucoma or cleft palate. If they have those additional findings, they're more likely to be associated with a syndrome. And they usually do fade within about 2 years. And then acrocyanosis, again, super common, but purple-blue discoloration of the hands and feet when exposed to cold. It does resolve with age, but parents can often get very distressed by seeing their baby's hands and feet turn blue and purple. So back to our case. You have a 3-day-old asymptomatic here with this rash kind of on the trunk and the face. And the differential for this doesn't have to be something, and it actually is not something that we talked about. But anyone have any thoughts on what it could be?
Enax.
Yeah, perfect. So erythema toxicum neonatorum is a pustular eruption with an erythematous base, usually in term neonates. It usually appears within the first couple days of life and resolves around up to 2 weeks. You don't really need, if you're for sure of the diagnosis, you don't really need any further workup, but again, because of the pustular appearance and on that red base, it can resemble HSV, which is scary and should have further workup. So if you are testing, you should obtain some smears for this, and specifically this smear will show eosinophils. So if you remember back to the transient neonatal pustular melanosis, that smear will show neutrophils. So that can be kind of a trigger in a test question if you were to get that. And moving on to infants, some of the things that we'll cover. First off with a case, so you have a 10-month-old that comes in with mom for an acute visit. She's had about 3 days of fever with a Tmax of 102 and an associated runny nose. Today she developed a new rash, has been increasingly more irritable, and is refusing oral intake. The rash is diffuse, maculopapular, it's not itchy, and it's mostly on the hands and bottom. She does have a 4-year-old sibling at home that has a sore throat but is otherwise fine, and both of these kids are in daycare. So again, just keep the case in mind, we'll come back to it. So diaper dermatitis, very common in pediatrics. It's a form of irritant contact dermatitis. It can sometimes represent early exacerbations of a more diffuse skin condition, such as seborrheic dermatitis, atopic dermatitis, or even psoriasis. You want to treat it with barrier creams, frequent diaper changes. You want to air the bottom out as much as possible, and using more sensitive fragrance-free wipes and soaps and lotions and things. Sometimes, even if it's bad, foregoing the wipes altogether and just using water to clean the area. If severe, sometimes we can put a low potency steroid cream on it, but we want to be careful about doing that. Some things that can play a part into diaper rashes are the stool pH, if they've had recent antibiotic use, and how many times that they have bowel movements. Some babies just go more than others, making them at higher risk for getting a more severe diaper rash. And then during some of my research, I came across this paper that was talking about breast milk and how it relates to stool and diaper rash. So breastfed babies have a lower stool pH, so usually have less severe diaper rashes. And then there was actually a randomized control study that was done in April of last year that compared the use of breast milk to hydrocortisone in diaper rashes, and over a week's time, they actually showed no difference in the outcome of them. So it did show that breast milk was just as effective as using hydrocortisone in diaper rashes.
Putting it on the rash or drinking it?
On the rash, yeah. So pretty interesting. Then candidal infections in the diaper area are beefy red plaques, usually have these satellite papules and can sometimes have pustules as well. Usually involve the skin folds, as you can see in this picture. The skin is kind of more moist and broken down in the skin folds, and then very red and having these satellite lesions that pop out on the sides of the rash. They can have a history of antibiotic use, diarrhea, or oral thrush that could clue you into this specific diagnosis. If they have persistent candidal infections, you want to start thinking about if it's an early sign of type 1 diabetes or an underlying immune deficiency. The treatment for this is nystatin. The timeline can vary, but usually you can use it for up to 2 weeks. And then seborrheic dermatitis. These are well-circumscribed erythematous papules and plaques that have a greasy yellow scale. So in these, the greasy yellow scale is going to be the key to in this differential. It's most prominent in the skin folds when it's located on the skin. When it's on the head, it's termed cradle cap. Usually with this treatment, you want to use lots of emollients and moisturizers to the area. You want to loosen up and moisten that scalar plaque that you are able to kind of wipe and brush out. Then if it's in the diaper area, you use a topical ketoconazole cream, and then a zinc-containing barrier cream as well. When it's on the body, you can use a short-term, low-potency corticosteroid or a topical antifungal. And then for these, you don't want to use high-potency steroids in the diaper area, because when it's occluded in the area, it does prevent or promote systemic absorption that can cause some adrenal suppression or a Cushing-type syndrome. So the least potent steroid is hydrocortisone, followed by the betamethasone and clobetasol in the low-potency category. And then moving on to scabies in infants. It can be widespread vesicular papular, often forming linear burrows. As you can see kind of on the bottom of this foot, they form in a more line along the skin folds. It is very itchy. Other family members will have symptoms as well, but it presents differently in adults and older kids. The treatment is with permethrin topically, and then wash it off several hours later, and then repeat again 2 weeks later. This is safe in babies 2 months or older and in pregnant or lactating mothers. Alternatively, you can use ivermectin as a single dose that you repeat in 2 weeks, but you want to be sure that they're over 15 kilograms. And then back to our case, so just overview is 10-month-old with a rash and a diaper on the hands and diaper area. You have fever, decreased oral intake, and irritability, sibling at home with a sore throat, and they are in daycare. Again, the differential isn't something that we have talked about so far. Thoughts? Yeah, hand, foot, mouth. So, type of viral exanthem. It's erythematous macules to vesicles surrounded by a thin halo of erythema that rupture to form ulcers. It can be different forms. You can have this macular red rash, papules or vesicles, usually on the hands, feet, in kids, more commonly on the bottom, and then oral mucosa as well. It's commonly caused by Coxsackie virus, amongst others, but Coxsackie is the most common. The symptoms usually resolve after 7 to 10 days, and again, these kids will kind of appear sick because it is a viral associated rash. the treatment for this is just supportive. The lesions in the mouth can be very painful, so you want to be sure that you're recommending Tylenol or Motrin, obviously depending on the age, but monitoring their hydration status as well.
I'll just say with this one, in the last few years, if you have an underlying eczema or psoriasis or anything like that, it looks 10 times worse than you're expecting, and it doesn't always follow the rules that it shows here, and it'll be exacerbated in the areas where you've had pre-existing eczema. So it really looks terrible, and it's like eczema herpeticum, so this is called eczema coxsackium.
Gotcha.
So any of those.
Good to know. And then moving on to a little older kids. So in children, this is our case. You have an 11-year-old with an intense itchy rash between their fingers. It's not painful. He is otherwise well. No changes to exposures, and no one else at home is sick, but he does recall that he thinks last year he had something similar. All right, so impetigo, also very common. It's a secondary infection from Staph aureus or strep pyo. You can have these pustules with honey-colored crusted erosions. You want to treat with Bactroban for about 5 days. If it's more widespread or diffuse, you can use Keflex. And then sometimes parents will come to you and say, well, can I just use this over-the-counter bacitracin or Neosporin? You should not use that. And then these kids can return to school or daycare after being on medication for 12 to 24 hours. You want to make sure you're doing lots of hand washing in this because it is contagious. Then perianal strep is bright red, sharply demarcated rash on the bottom. You can have fissures or blood-streaked stools. It's itchy and painful. It's caused by group A strep, and you want to treat with Bactroban for 5 to 7 days. Tinea corporis, so again, tinea infections, depending on the naming, depending on where it's located, but it's a dermatophyte infection on the body. It is itchy, usually circular or oval, erythematous, and hyperpigmented scaling patch or plaque that's in the shape of a ring with a raised border to it. It is transmitted skin to skin. You'll often, in a clinical question, they'll often present a wrestler that has these. You want to treat with a topical antifungal cream for a prolonged period of time for about 1 to 3 weeks. And ichthyosis vulgaris is a semi-dominant inheritance. It can appear in infancy or early childhood. It's a diffuse, fish-like scaly rash with a fine white or gray plaque. Usually spares the skin folds. You will have these thick, deep palmar lines that you see in this picture, and then also keratosis pilaris, which is the rough, bumpy skin on the back of the arms. It is improved in hot and humid conditions just because of the moisture, and the treatment for this is being sure that you are moisturizing the area appropriately. So long baths that can help remove that scale, and then applying thick emollients or moisturizers after. In babies, when they occur, they'll have the typical newborn-like skin peeling, but it will be more thick, and then underneath of it, the skin will be more bright red with even some fissures or cracks. If you do see this in a newborn, you want to be sure that you're providing them with lots of Aquaphor, and then usually they're placed in an isolette until they can, you ensure that they're not having excessive fluid losses from the rash. Then lichen striatus is asymptomatic, usually can be itchy, inflammatory skin disorder. You have these small pink or hypopigmented papules. They do form in the curvilinear distribution along the embryonic ectodermal lines of migration. Usually on the extremity, but it can be anywhere. It's self-limiting, around 6 months of duration, and then you can use some steroids if they're very itchy. So you can see here it kind of forms in the lines. Then molluscum is skin-colored, dome-shaped papules with a central indentation. They can be itchy, but they don't have to be. It is a chronic localized infection caused by a pox virus spread by skin-to-skin contact usually, and it does resolve within months, but can take up to a year just in healthy kids too. And then eczema or atopic dermatitis is chronic, itchy, inflammatory papules and plaques. They tend to involve the flexural surfaces of the upper and lower extremities. However, in infants, if you see it, it can pretty much be anywhere, but the diaper area is usually spared. It's often associated with elevated IgE, so family history, or they themselves may have some allergies or asthma even. The management is symptomatic and it depends on the severity. So again, you want to hydrate them or hydrate the skin. You can use topical corticosteroids if they have significant eczema flares. You also want to avoid some triggers and things like that. Then eczema herpeticum is it has multiple painful dome-shaped vesicles and vesicular pustular crusting lesions, as you can see in this picture. Rapid onset and spread. It is a complication of eczema, as we kind of mentioned before, similar with the Coxsackie virus. They often will appear sick and have a fever. It is associated with HSV1 or 2, and then the smear is diagnostic, but you want to treat these kids with IVI cyclovir. And then a drug rash. Most common drug hypersensitivity reaction, which is a type 4 reaction. It is generalized symmetric eruption of erythematous macules or papules. It can be itchy, but it doesn't have to be. It does not involve the mucous membranes or internal organ involvement. But if it did, it would be not necessarily just a drug rash, but it would be, you want to think about Stevens-Johnson's or TIN or Dress syndrome. So the timeline for this can vary, usually depending on if they've been exposed to it or not before. So it can occur within hours or even up to 2 weeks after starting the offending agent. So for this, you obviously want to stop whatever it was that they were on that caused it. And then you can treat with a topical corticosteroid or an oral antihistamine just for the itchiness of the rash. If really severe and widespread, you can give them a 3-day burst of oral steroids as well. And then going back to our case. So this is an 11-year-old with intense itchy rash between his fingers. He's otherwise asymptomatic, but did have the same rash last year. Any thoughts on what this one could be?
Could be scabies, but what?
Could be scabies, but again, with the last year picture. So this one is dyshydrotic eczema. It is pruritic, firm, multilocular vesicles that can be confluent and form bulla. It's most commonly on the palms or soles or the lateral aspects of the fingers. It is recurrent, so you'll often see them pop up each year. Sometimes it could be related to hyperhidrosis if they're very sweaty. The treatment for this is, well, if it's due to the hyperhidrosis, you want to make sure it's dry, but then alternatively, you want to make sure the area is moist. So you can use some wet dressings, emollients, or even topical steroids if they're severe. And then lastly, moving on to our adolescent age group. So this case is a 17-year-old girl who presents with a rash that you see here. It started 3 days ago while she was on vacation with her family at an indoor water park. She has a little bit of malaise, but no fever or other infectious symptoms, no allergies. She's not had any recent medication use. All right, so acne vulgaris can have various presentation, but you can have open or closed comedones or inflammatory pustules. If severe, it can be more cyst-like or nodules. The cause of it is multifactorial, but Cutibacterium acnes overgrowth is thought to play a part, as well as keratin obstruction and then increased sebum, also related to hormones in many cases as well. The management depends on the severity or the type. So for the management, if it's mild, you want to start with a topical retinoid and benzoyl peroxide, but you want to apply these at different times of the day because the retinoids deactivate benzoyl peroxide. You can also use a topical antibiotic, such as clindamycin or erythromycin. If it's more moderate, you can try a course of oral antibiotics with usually doxycycline. And then more severe, so the severe form would be the more cystic acne, which in this picture you can see usually scars, so we want to try to prevent that scarring. You can use isotretinoin or Accutane. And with isotretinoin, you want to keep in mind that it's associated with severe birth defects, hyperlipidemia. They can have elevated liver enzymes and severe mucocutaneous drying. So adolescents that are on this medication, you want to be sure to monitor very closely. And psoriasis is a systemic immune-mediated disease. It usually is well-demarcated erythematous plaques with an adherent scale. The removal of the scale will have this pinpoint bleeding. You can see some pitting in the nails, which is a common pearl that you'll see in questioning when you're like board studying and things to lead you into this diagnosis. There are different forms, but chronic plaque psoriasis is the most common in kids. It can involve the face, scalp, and the skin folds, including the diaper area. Management, again, is highly dependent on severity, but you can use some medium to high potency steroids, calcineurin inhibitors, vitamin D analogs, and emollients. And in kids, these can be both on the flexural and extensoral surfaces. I know it's different in adults, but in kids it can be both. And then another form is putate psoriasis. It is a sudden onset. You'll have numerous small, discrete, they often term them drop-like erythematous papules and plaques with a fine overlying scale. They're mostly on the trunk and proximal extremities. They resolve spontaneously. In some cases, they can represent an initial stage of chronic psoriasis. It frequently follows a upper respiratory infection or strep throat. The management for this is hydration of the skin. So with emollients, you can use a topical steroid or vitamin D. If it's very severe, sometimes requires derm involvement. And pityriasis rosea is benign. Starts as a isolated oval scaly pinkish patch known as the Harrell patch that you see here. And then it's followed by multiple smaller scaly oval patches that vary in size and will often be located on the back in they term a Christmas tree distribution, so you can see it kind of coming down all the way down the back. It does resolve in about 2 to 3 months. You can use short-term topical steroids for the itching. The tinea versicolor can be asymptomatic. They can also have itchy lesions, so they will be papules and plaques with a fine superficial scale. They'll often be red, brown, or white in color. Usually it's on the trunk. It is fungal, and in questioning with this one, they'll often describe the spaghetti and meatball pattern, which correlates to the hyphae and spores. The management for this is a selenium sulfide shampoo for about 2 weeks. Then you want to follow with a maintenance regimen with that, doing weekly applications for months after use. Then alternatively, you can use a ketoconazole shampoo, terbinafine. You can also use a single dose of ketoconazole that they will take and then encourage exercise after so that they sweat and the medication gets out onto their skin. And then going back to our case, you have this 17-year-old who is coming in with a rash that started 3 days ago while she was vacationing at a water park. Any thoughts?
Hot tub folliculitis.
Yeah, perfect. So hot tub folliculitis, it's caused by a Pseudomonas. It usually develops within 1 to 2 days after exposure. You'll have numerous discrete papules, nodules, or papular-pustular lesions, so it obviously can vary. It is itchy oftentimes, and it's located mostly where the bathing suit will cover because that's where it kind of is like sticking to. It is linked to hot tubs, pools, and water slides. The management is symptomatic. So you want to be sure that all of your hot tubs and baths and things that you're getting into are thoroughly cleaned. And then if you're swimming, you want to make sure that the water contains accurate or adequate levels of chlorine. Usually will resolve within 1 to 2 weeks. All right, so some questions. First question, on initial newborn exam, you have a term female that's found to have multiple superficial, intact, and recently ruptured pustules overlying the posterior neck, the upper portion of the trunk, and proximal portions of both upper extremities. There's several hyperpigmented macules that are also present. Which of the following is the most appropriate step in the continued treatment? So you have A, RPR on both mom and baby, B, ANA and anti-double-stranded DNA on mom, bacterial culture of the vesicular fluid, no additional evaluation, or get a zinc smear of the vesicular fluid.
D.
Yes, D. So do we know what this is?
Neonatal pustular.
Yeah, so the transient neonatal pustular melanosis. And it's common, benign, presents at birth, and it will resolve. In question 2, a 12-year-old boy presents with a history of a rash that has continued to worsen over the last 10 days. On physical exam, you see multiple discrete drop-like papules with a pinkish hue. Some have a fine, scaly appearance to them. Lesions are most prominent on the trunk and proximal extremities. The palms and soles are spared. Which of the following conditions is most likely to be associated with this disorder? So you have recurrent episodes of hematuria following a URI, autoimmune thyroiditis, a sore throat within the preceding 2 to 3 weeks, recurrent episodes of skin and soft tissue abscesses, or sensory neural hearing loss and chronic kidney disease. C, yes. So we know what this one is?
The gut psoriasis.
Yeah, so that is associated in about 80% of cases with prior strep throat infections. And then lastly, we have a 16-year-old boy who presents with a pruritic, painful rash on the hands and feet for the past 2 weeks. He denies fever, fatigue, or any history of chronic rashes in the past. On physical exam, there's multiple erythematous vesicles and several bullous lesions with fissuring, maceration, and scaling of the interdigital webs of the 3rd, 4th, and 5th toes on both feet. There's multiple vesicles on the palms and along the sides of his fingers. Which of the following is the most likely diagnosis? So A, tinea pedis associated with autoeczematization, bullous impetigo, secondary syphilis, eczema herpeticum, or scabies.
E.
Scabies, 1. This one is actually,
A.
yeah, this one is actually A. So this is not something that we had talked about, but I got a question about it and thought it was interesting. But it is a dermatophyte or an ID reaction. So it's a hypersensitivity reaction to a recent tinea infection. You treat it with topical antifungals You want to keep the area as dry as possible, but you want to continue any oral any oral antifungals that they were on. The rash will usually resolve after 2 to 4 weeks with this one. All right. Finished a little early. I thought I was going to run late on time because I had a lot, but I kind of flew through that.
Question, that first MOC question, what's your tip off that it's you don't have to do a Zank smear or think about HSV, and how would the pigmentation of the patient affect that? I'd worry in a darker skin tone, I would not recognize the hyperpigmentation, which to me, I guess, is one of the clues that it's not potentially.
Yeah, so I think the key for like the first part of your question was the several hyperpigmented macules that are also present. That would be consistent with the melanosis versus the HSV. And then as far as on different skin colors,
It looks obvious. It's much more hyperpigmented. It's actually much more common in African American babies.
And I don't know, historically, it seems like they're pretty small.
They're just little dots.
Almost like pinpointy, yeah. I think your question, though, if you were ever worried, you gotta, if you're thinking herpes.
The timing also helps, because herpes you typically see around a week old, and this is the initial exam.
thoughts or questions?
With the cafe au lait, we've picked up numerous neurofibromatosis just from being, I'm almost paranoid now, so if I see anything coming close to 5 or spots, and it depends on the size. So the diagnosis is, I think it's 5 if it's on the 0.5, and it's 6 if it's larger one. So the criteria for NF1 is different. But you'll only see a few, and as they grow, you'll see more. So it's important if you document, well, I only saw 4 when he was 6 months old, and now he's 2 years old, and he's got, like 15, immediately send them off for testing. And many times, because it's autosomal dominant, the parents also have it, so they didn't think anything of it. We all have these birthmarks in the family, all 50 of them. So, and we've picked that up in like multiple family members got diagnosed at the same time.
Interesting. Yeah, they're pretty common, but it is like, I'm sure once you've seen it, you're always on the lookout for it after that, but.
Particularly when we have kids that come in for seizures that we assume are febrile seizures or whatnot, it's important to do a good dermatologic exam, because occasionally we'll pick up that too. They'll have 7, 8, 9 of these. It's like,
Yeah.
You get the MRI and it starts to show lesions where we assumed it was a febrile seizure.
I haven't had it in a few years, but it used to be almost every other year that you got a call from CPS for bruising, and it was the
Congenital dermal disease.
The changed term.
The change term, yes. So I try to tell my patients, like, if you're going to a new babysitter or you're going to a new daycare, point out, this is the birthmark my child has already. It's not, I'm not beating my child, or they're not beating your child. They're actually just birthmarks that look a lot like bruises.
Yeah. I think it also is very important, especially in the darker pigmented babies, because, heard lots of horror stories about it.
I want to thank Dr. Estep for her excellent presentation.